Good afternoon. This is Dr. McDaniel at GYN Corner. I'm a board-certified obstetrician gynecologist in New York City, Midtown Manhattan, and I'm bringing to you all things health-related for women. Thank you for joining me today at GYN Corner. This is the Facebook Live page, and please check out the YouTube page. The YouTube page is, or I guess it's called the YouTube channel. The YouTube channel is also called GYN Corner, and we have podcast GYN Corner available on 8 different platforms: Spotify, Google Podcast, Apple iTunes, Podcast Addict, and Anchor, and a few more. So please check out the podcast. Please leave reviews and comments with questions that I will be more than happy to answer, and with suggestions for content. If you have topics you'd like to see addressed, please let me know and I'll be able to do that for you. Anything related to women and health, I'm more than happy to address. So in the last couple of presentations, I've been speaking about ovarian cyst, and in the previous presentation, I spoke about the different types of ovarian cyst. So a cyst is a pocket of fluid. It's a bag of liquid. A tumor is different than a cyst because a tumor is a solid ball of solid tissue, whereas a cyst is just liquid. And any of the potential types of tissues present in the ovary you can have as the wall of an ovarian cyst. Sorry. So as I mentioned previously, we have normal cystic changes. Those are called functional cysts or hormonal cysts, which allow the reproductive system to function. Those are follicular cysts, which allow one to produce an egg for pregnancy. Those are those pop out of the cyst at ovulation. And we have a hormonal cyst called a corpus luteal cyst or a hemorrhagic cyst, which produces hormones that if someone gets pregnant, it supports the pregnancy for the first 10 to 11 weeks of pregnancy. So those cysts come and go every month, and they're perfectly normal. They're supposed to occur. Abnormal cystic changes can be from the skin of the ovaries, or from the meat of the ovaries, or from the primordial eggs, the follicles, we call those, or what we call sex cord and stromal tumors or germ cell tumors. So you can have skin of the ovary, which are epithelial cells, and the epithelium can produce watery liquid called a serous liquid, and that's today's presentation. It's a serous cystadenoma. So serous cystadenoma is one of the popular types of cyst, the epithelial cell cyst. It's a smooth, thin-walled, kind of glossy type of ovarian cyst. It contains just water, so what we call a straw-colored or a slightly pale yellow tinge type of water. Now, most of these cysts, the serous cystadenoma, they are usually quite large by the time we discover them. So they can range inside from as small as 2 to 3 centimeters up to, I think the record was a 30 centimeter serous cystadenoma. 30 centimeters is about the size of a 7.5-month pregnancy. So almost an 8-month pregnancy is 30 centimeters. And 2 to 3 centimeters is like the size of a table grape or cherry tomato, grape tomato even. So pretty tiny. But on average, when serous cystadenoma is discovered or detected, it's usually around the size of a grapefruit. So usually around 8 to 10 centimeters, or cantaloupe, 10 centimeters. It's the average size of a serous cystadenoma once it's identified, discovered, identified, and treated. And we do always remove them because they will not go away on their own. It's a thin wall, but it's a fairly thick, firm wall, so they don't usually rupture on their own. Or if there's trauma to the abdominal pelvic cavity, they don't usually rupture. They're pretty thick and firm and tough. Smooth, thin-walled cysts, and they don't have a lot of compartments. They're usually unilocular cysts, so just one big bag of pale colored, or what we call serous fluid. The serous cystadenoma is responsible for approximately 16% of the ovarian cysts that are detected, and we call them neoplasms because some of them are pure cysts, some of them are a combination of cystic, liquid, and solid tissues, so we call them neoplasms, which means an abnormal growth, because it is an abnormal growth. The majority of the majority of cystadenomas are benign. You can have benign and you can have malignant cystadenomas. Approximately 60+% of cystadenomas, serous cystadenomas, are benign, so they're not cancerous, they're not malignant, they're just sitting there slowly growing over time. Now, most women who have a cystadenoma, serous cystadenoma, are not going to have symptoms. They don't cause pain, they don't cause burning, they're completely undetectable by the patient, except occasionally if they slowly get larger and larger. Sometimes with intercourse there'll be pressure, discomfort, or an achy sensation from the cyst being pushed and moved around. We will usually pick them up on the annual exam. When we do the physical exam of the pelvis, that's called bimanual, we can feel that either behind or in front of or next to the uterus there's a firm mass of fullness that's not normal. And then the imaging study of choice is always going to be a sonogram or an ultrasound. The ultrasound or the sonogram is used to determine if there is an abnormal mass or fluid collection in the pelvis, and to identify blood flow to the mass. Benign cystic changes usually have very minimal blood flow. Malignant or cancerous changes usually have quite a bit of blood flow because cancer always garners an abnormal blood supply. And the serous cystadenomas are about 10 to 20% of the time they're on both ovaries. So sometimes they'll be detected on one ovary, surgery will be done for that ovary, and then a few years later it'll be the same story on the opposite ovary, and then occasionally they're detected at the same time. So we see a large cyst on one ovary, we go in to do the surgery, there's a smaller one on the other ovary. So 10 to 20% of the time they are on both ovaries bilaterally, either at the same time or at different times. The majority of women who have a serous cystadenoma are middle age, so they're usually around 40 years old. Between 40 and 60 is the average age. And as I stated on a previous presentation, if the cyst gets to be quite large is considered over 5 centimeters, so larger than a navel orange, so a grapefruit or larger. Sometimes they can twist on their ligament, supporting ligament. That suspensory ligament or supporting ligament has blood supply in it, so if it gets unbalanced, we call it a torsion, and if it torques or torsion occurs around that suspensory ligament, it can potentially cut off the blood supply, and that will cause severe pain as the blood supply is cut off, and that ovary will start to die off or necrose. So that's a medical emergency. Most of the time, because these serous cystadenomas don't have a difference in weight on either end, most of the time they just sit there in the pelvis and they like a lump, and they just slowly grow. They don't have any difference in weight, so they don't usually torque or turn on that suspensory ligament. So that's the good news with it. So I hope that's been helpful information on one of the epithelial cell ovarian cyst, a serous cystadenoma, which over 60% of them are benign. So serous cyst, over 60% of them are benign. They're asymptomatic, picked up incidentally on imaging studies or on a physical exam, and the treatment is always going to be surgical removal because they will never go away on their own. So surgical removal is just a cystectomy. Can't talk today. It's a cystectomy, and it's usually done in day surgery. We use a camera, laparoscopic ovarian cystectomy. We peel off the ovarian capsule that contains the cyst, and then we remove the cyst from its base, pedicle or base in the ovary. And the recovery is easy if it's done in day surgery. You go home the same day. Most people do it on Thursday or Friday. They have the rest of the weekend off and they're fine. So I hope that's been helpful information. This is Dr. McDaniel at GYN Corner. Please hit the like button if you like the presentations. Click the follow button and you'll get a heads up on when the presentations are occurring, what the topics are. And please check out the YouTube channel. Hit the follow button on YouTube and rate, put reviews up on the podcast to let others know that you enjoy GYN Corner, what you enjoy about it. And please hit me up with questions and hit me up with topics. I'd be more than happy to discuss them. So I'll be back at the next presentation. I'm going to continue the series here on ovarian cyst. I hope everyone has a lovely rest of their Tuesday. Bye.